Hello, in this clip we're going to be talking about rheumatoid arthritis. Rheumatoid arthritis is an inflammatory systemic disorder which is initiated by a non-suppurative proliferative inflammation of the synovium, which causes a great deal of articular erosion and, as a consequence, bony ankylosis. It affects about 1% of the world's population, with a higher prevalence in the 50 to 70-year-old age gap, with increased rates in women of about 3 to 5 times more. The pathogenesis, as it currently stands, involves a genetically susceptible individual being met by an environmental pathogenic antigen. When we say a genetically susceptible individual, there are a few genes that have been highlighted in various forms of literature. Of key interest to me is HLA-DRB1, which encodes the hypervariable region in the beta chain and is involved in the initial inflammatory response, as well as PTPN22, which encodes the tyrosine phosphatase. Environmental sort of pathogenic antigens have been found to be associated with rheumatoid arthritis, which include EBV, paranorovirus, retroviruses, mycoplasma, Borrelia and Proteus mirabilis, as well as citrulated proteins in the lungs of smokers. And all this causes is that there's an autoimmunity process within the individual, which results in CD4 T helper cells being found early on within the synovium. T helper 17 cells help recruit neutrophils in this case, and about 80% of individuals will have autoantibodies autoantibodies of the Fc fragment of the IgG, which mostly come in the form of an IgM autoantibody, and this forms immune complexes by self-associating, and otherwise this is also known as rheumatoid factor. Some patients will also have antibodies to citrullinated modified peptides, which, if found with T cell involvement, suggests a more aggressive form of disease. So what does this mean for synovium? It all means that there's increased likelihood of there being interferon gamma and interleukin 17 upregulation, which increases sinusocytes and macrophages to secrete interleukin 1, 6, 23, TNF, nitrous oxide, prostaglandins, GF beta, and all of this results in the endothelial cells increasing matrix metalloproteinases, which causes the articular cartilage to increase rank ligand, which then causes osteoclastogenesis and osteoclast activity. This allows the potential for the synovium to grow over the articular cartilage, which in the chronic form causes pannus formation and stimulates bone reabsorption. Pannus formation in this case is an irreversible, sustained damage of the articular cartilage and the presence of subchondral bone erosion. So now that we know sort of the pathogenesis, how does it relate in sort of clinical terms? Well, you need to think of it as affecting the joints, the skin, the vessels, and also certain organelles. So when we talk about the joints, it tends to affect the small joints in a symmetrical fashion. So you're looking at the fingers, the toes, the wrists, the ankles, the elbows, and the knees. And in the hands, you kind of get visible signs of the disease as it progresses, so because it affects the tender ligamentous insertions. So you can get radial wrist deviation, ulnar finger deviation, flexion, hyperflexion, and extension, deformities of the fingers in the form of swan neck and boutonnieres, as well as palmar subluxation. In terms of vasculitic sort of complications of rheumatoid arthritis, this tends to occur later on as you have increased risk of obtaining vasculitic syndromes, which affect the medial and small arteries, and so there's a chance of sort of organelle infarcts, as well as vasa novorum and digital artery involvement, which can lead to a high susceptibility to gangrene neuropathy and ulcer formation. Of key interest is leukocytoclastic venulitis, which is a nail bed infarct and cutaneous sort of ulcers, as well as vasculitis. Purpura. Purpura. So that the other manifestations can occur solely by themselves, so you can get nail bed infarcts by themselves, as well as getting widespread cutaneous vasculitis. You can also get mononeuritis multiplex and bowel infarction. Other sort of other organelles which are affected, especially includes the lungs. The lungs can be affected via a pneumoconiosis and a bacterial RA, which is also known as Kaplan syndrome. You can also get infective lesions, pleural nodules, as well as serositis, and as well as sort of a fibrosing alveolitis and obstructive bronchiolitis. In the form of the cardiovascular system, you have increased risk of CVD. Neurologically speaking, you only tend to get sort of those findings when it actually sort of impedes on the nerve, the inflammation of the surrounding tissue and joints. So you can get median compartment syndrome, for example. Anemia tends to be a common sort of finding, which is Combs positive for that test, and pancytopenia as well is also present in some cases. Thaltes syndrome is an interesting thing to look out for, which is basically rheumatoid arthritis, a splenomegaly, and neutropenia. Kidneys are actually involved secondary to amyloidosis. So rheumatoid arthritis is the most common cause of secondary amyloidosis, which then causes the presence of nephrotic syndrome in rheumatoid arthritic patients, and there's also a complication of having a high risk of septic ulcers. So when you think that your patient has rheumatoid arthritis, you need to give them an X-ray. An X-ray will have four distinct sort of features. So joint effusion may be present. There will be loss of joint space. There will be juxta-articular erosion with osteopenia and osteophyte formation. When you try to diagnose rheumatoid arthritis, you need to get 4 of the 7 of the following. So it tends to be morning stiffness, 3 or more joints being affected, or the arthritis of the hands. You get symmetrical arthritis, rheumatoid factor, a rheumatoid nodule, or typical sort of radiographic hallmarks, as just stated. So now we come to management. Management tends to now be the form of providing sort of pharmacological therapy early on. So you'll start to disease modifying anti-rheumatic drugs pretty early on, and this can be in the form of sulfasalazine, which has quite sort of tolerable side effects, and it tends to have a better effect in young and women patients. Methotrexate can also be used, but it tends to alter your liver and kidney biochemistry, and you need to also have that with folic acid. You can also have luflunomide, which needs to have a washout period of about 2 years before conception, so you need to be wary about it in patients who can be of that childbearing age. TNF alpha blockers currently under NICE guidelines are suggested after you have active RA disease of more than 5.1 on 2 occasions a month apart, after 2 trials of DMARDs which have lasted 6 months. Etanercept can be used, adalimumab and infliximab. Etanercept tends to have autoimmune sort of syndromes associated and demyelination problems, but they're quite rare, so you can become ANA positive as well as have lupus-like syndrome. Other biological agents that are commonly used are anakinra, which is a interleukin-1 antagonist, and remember we said that was part of the pathogenesis of rituximab. That's also important, and that's a monoclonal antibody, as well as abatacept. Less commonly used drugs include gold, hydroxychloroquine, which is anti-malarial, but also has a side effect of causing retinopathy. Penicillamine tends to also be used, but that can cause lupus erythematosus-like syndrome, or myasthenia gravis-like syndrome. Azathioprine can also be used, but that tends to cause liver toxicity. If you're TPMT deficient, and lastly you can use cyclosporine. And that concludes the management of rheumatoid arthritis. Thank you for watching.